Hi everyone, let's do some quick review for neuroradiology board exam type of question. Let's do 11 question multiple choice questions, and each question I'll give you about 11 seconds to do it. So of course feel free to pause if you need additional time, and the explanation will come after all the questions done. Case 1 is trauma. The answer is B. Case 2. This is agenesis of corpus callosum. Case 3. This is osmotic demyelination syndrome. Case 4. Non-contrast CT first, followed by this contrast exam. Answers venous infarction. Case 5. Coronal suture craniosynostosis. Case 6. DVA. Case 7. Cavernous malformation. Case 8. MRI. CT. This is fibrous dysplasia. Case 9. Meningioma. Same patient with additional finding. With that additional finding, what's your differential diagnosis, or what's your diagnosis? This is NF2. Case 10. This is from radiopedia of a particular imaging finding on the left orbit. This is our patient with a same finding except with less exaggerated finding compared to radiopedia finding right here. With additional finding on FLAIR sequences, what's your diagnosis? This is NF1. Last case. This is multiple sclerosis. So how many did you get it right? So for case 1, it's a trauma. Here, the answer is facet dislocation bilaterally. On axial view, a normal facet joint looked like a hamburger. This one, on the other hand, looked like the hamburger bun has been flipped. This is referred to as the reverse hamburger bun sign. This signifies facet dislocation. And on the left side, signified by the red arrow, this is a jump facet dislocation. On the right side is less severe. This is a sublux facet dislocation. And there are 3 main types. So the less severe type is when there's a slight displacement, that's sublux facet dislocation. If the inferior articular facet perches on top of the superior articular facet in the lower level, this is the perch facet dislocation. The most severe type, such as one in the red arrow right here, the facet joint has jumped. That is the jumped facet dislocation or the locked facet dislocation. Next case. On this fetal MRI, you have a classic finding for callosal dysgenesis or agenesis of the corpus callosum. Here on the coronal view, you have a frontal horn that is upturned that look like a Texas Longhorn. So this is a Texas Longhorn sign. A normal, the lateral ventricle or the frontal horn lateral ventricle is being held down by a intact corpus callosum. Lack of corpus callosum can cause this upturn of the lateral ventricle or the frontal horn or lateral ventricle, consistent with Texas Longhorn sign. And with that, you will see high-riding third ventricle. And also, you will see this parallel appearance of the lateral ventricle on the axial view, as well as dilatation of the atrium and the occipital horn of the lateral ventricle, consistent with colpocephaly. Those are the classic findings for agenesis of corpus callosum. On the sagittal view, you can see that the corpus callosum is entirely missing. Coronal view, you have that classic Texas Longhorn sign. On the axial view, you have parallel appearance of the lateral ventricle as well as colpocephaly. Other association they can ask you is there's association or higher association with interhemisphere fissure cyst as well as pericallosal lipoma. This is interhemisphere fissure cyst. There are 2 types. If there's a communication between the cyst itself and the third ventricle, so in other words, large diverticulum, that's type 1. On the other hand, if the interhemisphere fissure cyst does not communicate with the third ventricle, you can see there's separation. That is type 2 cyst. Lipoma, Bryan T1, pre-contrast. If you suspect anything that has a fatty tissue, you should do fat saturation sequence, such as this T1 post-contrast with fat sat. The bright signal disappeared. On T2 weighted sequence, you can also see that there's a fat saturation. So this is consistent with lipoma. On the, again, coronal view, you see that Texas Longhorn sign. And on the axial view, you have that parallel appearance of the lateral ventricle, consistent with agenesis of the corpus callosum. Next case. This one has a classic picture of osmotic demyelination syndrome. So on the axial view, that's called the piglet sign. You have a preserved corticospinal tract. So therefore, that looked like a snout of the pig, and the fourth ventricle looked like the mouth of the pig. This configuration right here also looked like a trident. So sometimes referred to as the trident sign. And on the imaging, often you see diffusion restriction, and typically you do not see any enhancement on the post-contrast images. Now, the classic presentation is that patient has a rapid correction of hyponatremia, but other electrolyte imbalance can also produce osmotic demyelination syndrome. It's often referred to as central punctate myelolysis, but it's probably better to refer to as osmotic demyelinating syndrome in that there are 50% of the time you can have extra punctate involvement, such as involvement of the thalami, basal ganglia, as well as subcortical white matter. This is an example of somebody who has both of a different patient than ours. Next case, severe headache. On the non-contrast CT, you can see there are multiple areas of acute parenchymal hemorrhage. On the non-contrast, in the area of posterior superior sagittal sinus, that density is too high. So now I'm concerned about acute thrombus within. When you suspect that, of course, you want to do a CT venogram, and sure enough, you see an empty delta sign. There's a filling defect within the delta of the posterior aspect of the superior sagittal sinus, and the corresponding finding on the non-contrast CT is that you see increased density within the triangle. So on CTV, you see this filling defect. That's the empty delta sign. Next case, concern for non-accidental trauma. Here you have a plain radiograph. What you see is that the left side of the orbit is normal, but the right side of the orbit had this elongation, or the corner has been lifted, and that appearance looked like a mask of the holoquin. Imagine you have a bilateral finding that does look like a mask of a holoquin. That's referred to as holoquin deformity or holoquin orbit sign. So if they ask you about suture or the closure of the suture, the first one that should be fused is pretty early on. That's metopic suture. Of course, you also have coronal suture, sagittal suture, lambdoid suture. The metopic close very on as early as 3 months. For the coronal and sagittal is about 20 years, so into the adulthood, and the lambdoid is even later. So if you remember, the function of the sutures allow the brain to expand or allow the calvarium to expand during the rapid brain growth. So if you have, for example, the coronal suture that's prematurely fused, so your calvarium does not have the ability to elongate in the AP direction. So the head has no choice but to expand in the transverse fashion. So you have the classic brachycephaly for bilateral coronal craniosynostosis. On the other hand, if the fusion occurs with sagittal suture, now the brain does not have the ability to expand in the transverse dimension. So you will elongate in the AP dimension. So produce the classic appearance of scaphocephaly or dolichocephaly. For premature suture of the metopic suture, you can have a triangular appearance, so trigonocephaly. This is an example of the patient on the left side of the coronal suture is open, the right side of the coronal suture is closed. Here you can see the holocrine deformity. Next case, vertigo. Here you can see a large vascular structure. This is developmental venous anomaly. So if you look at this particular structure, it looks like the head of Medusa or Captu Medusae sign. The little snake, the hair of the snake that's draining into the head of Medusa, and the large draining vein signify the body of the Medusa. It takes some imagination to see that, I fully admit, and maybe it's better known as the palm tree sign. Next case is seizure. Here, this is a classic picture for cavernous malformation, particularly on the T2-weighted sequence. You can see centrally is lobular, multilobular, is bright on T2-weighted sequence, has a complete hemocentrum T2 hypointense rim. Because this contains blood product, there's variable signal within the central cavernous malformation, could be T1 bright, such as in this case. On post-contrast, it should not enhance. This is an intrinsic T1 shortening right here. However, you may see association with the adjacent vessels such as DVA. So think about the increased chance of seeing DVA associated with cavernous malformation. The cavernous malformation is often like to a configuration of popcorn, so the popcorn sign. Here's another example of popcorn sign. I like to call that a chocolate coated popcorn or caramel coated popcorn, in that if you take a popcorn that's coated with chocolate, cut it in half, the central portion is bright on T2 weighted sequence. It's surrounded entirely by the complete hemocentrin rim, such as a dark chocolate around. So chocolate coated popcorn sign. And remember, increased association with DVA. Next case, hearing loss. On the MRI, you can see there's quite a heterogeneous, bizarre-looking expansile calvario lesion. Heterogeneous enhancement post-contrast. Now, whenever you see a lesion that involving the bone structure, it's always a good idea to get a CT to get a evaluation of what the bony detail look like. Here you do see that classic appearance of a ground glass sign or ground glass density sign. So for those of you who doesn't know what ground glass looked like, this is a picture I took in Japan, in a rural village in Japan. For privacy reasons, you have this smoky appearance of the density across the glass. So it has that homogeneous, smoky glass appearance, the ground glass appearance. Look exactly just like that. And that is really good for fibrous dysplasia. Next case, I think the key word here is painless. Here you have an optic nerve sheath meningioma. Notice that the optic nerve itself is not involved. It may be constricted, but the signal is normal. What's abnormal is this increased thickening and enhancement surrounding the optic nerve. On the axial view, that's referred to as a tram track sign. On the coronal view, that's referred to as a donut sign. Additional finding for this patient, you can see multiple other lesions, including bilateral vestibular schwannoma. So this, of course, is NF2. This is different patient, has additional spinal disease. So think about NF2, chromosome 22. The way to remember is the classic finding for NF2 is bilateral vestibular schwannoma. So bilateral 2 and 2, so chromosome 22. And also think about Missman syndrome, multiple inherited schwannoma. So bilateral vestibular schwannoma in particular, multiple meningioma like we see in this case. And sometimes in the spine, you can see an intramedullary tumor that is ependymoma for NF2. Number 10, histories of no. Here on a picture from Radiopedia, you can see that the left orbit looks like as if it's empty, right? On the right side, you can see the superior orbital fissure, inferior orbital fissure. In a less exaggerated case, in our case, you can see the superior orbital fissure is abnormally whitened compared to the left side. That is due to fibrous dysplasia, or that's due to the sphenoid wing dysplasia. And additional finding with loss of T2 flare signal abnormality involving the bilateral basal ganglia, often globus pallidus. This is consistent with NF dysplasia or FASI. And the sign itself is referred to as bare orbital sign, secondary to sphenoid wing dysplasia. This is NF1. Now with NF1, they can ask you additional findings such as optic glioma, a vascular lesion such as moya, FASI or NF dysplasia. Those are those in non-enhancing flare hyperintense lesion, often involving the basal ganglia, particularly globus pallidus. Another common location would be mesiotemporal lobe, hippocampi, thalami, dorsothalami, and the dentate nuclei of the cerebellum. In head and neck, and in the spine and the body, you can potentially see plexiform neurofibroma. This is a good example of a large plexiform neurofibroma that you can see very well on STIR. In the spine, you can see duroectasia as well as lateral meningocele. With duroectasia, you often see posterior scalloping of the vertebral body. Sphenoid wing dysplasia, as we talked about earlier, in extreme cases can produce bare orbit sign. Less nitro is not something we see in radiology. That is a clinical finding. And for NF1 is for NF2 is chromosome 22, right? Bilateral vestibular schwannoma, bilateral 2 and 2. For NF1, it involves chromosome 17. How do you remember that? There's a dumb mnemonic. The old name for NF1 is Van Recklinghausen disease. If you think you know how to spell Van Recklinghausen, there's 17 letters in there. Really dumb mnemonic. By the way, Neurofibromatosis also has 17 letters inside, so chromosome 17. Last case, patient with acute stroke-like symptom. Here you have a particular appearance of the post-contrast enhancement. This is multiple sclerosis or tumefactive multiple sclerosis. On the diffusion, you can see this restricted diffusion along the peripheral aspect of the lesion. This is often referred to as the horseshoe pattern of enhancement or incomplete rim, open rim enhancement pattern. So the idea is that enhancement represent the advancing front of the demyelinating white matter. So often the open rim is pointed toward the gray matter. So if you look at in general, if you see a rim enhancing lesion or rim enhancing parenchymal lesion, there's a long differential diagnosis that you can think about. Not very helpful. It's a long differential diagnosis, rarely helpful, but it's magic doctor, so metastasis, abscess, GBM, subacute infarction, contusion, demyelinating disease, radiation necrosis if the history fits. So essentially, when you see a rim enhancing lesion, you have to think about, does this represent neoplasm, such as, for example, metastasis or high-grade glioma? Does this represent infection, such as abscess, rim enhancement? Right? Or could this be entirely something else, such as tumefactive demyelinating disease? Or if history fit, could this be radiation necrosis? If I were to show you 5 different patients, try to do the match, right? The enhancement pattern become important because in this case, there's only one patient that has an incomplete rim enhancement pattern or horseshoe enhancement pattern. So that is patient C. Patient C, you have an incomplete rim enhancement. So it turns out patient C does have multiple sclerosis. So that's tumefactive demyelinating lesion, just like the patient that we have, as I showed just now. This is another case of tumefactive demyelinating lesion, has even a more incomplete rim enhancement. This patient right here has multiple sclerosis, has an active inflammation. Know that the multiple sclerosis lesion, some lesion, not all of the lesion, some lesion shows enhancement and is again a horseshoe or incomplete rim enhancement pattern. That's all. Thank you very much for your attention.